Good evening, friends. We are going to discuss MGR University essay questions. These are essay question sessions we are conducting under Dr. Drills. Good evening, all. So, these essay questions of MGR University, we are going to have most of the essay questions of the last 5 years we are planning to conduct. And you can see the last 3 years, the interesting papers are, last few years, the interesting papers are from CBME Curriculum. The latest curriculum-based questions they are asking. In essay question, if you see, 2 essays coming per paper. So each contains 15 marks, and totally we have 30 marks per essay question. And 10 short notes, each having 5 marks for 50 marks. And 20 MCQs which are having 20 marks. This is the pattern we are having for the MGR University. So you'll get an idea. We are mainly focusing on essay questions because MCQs, we found it they're very easy and you can get MCQ discussions from our app, online app. And we will be discussing all the essays, and according to the time permission, we will go for future some short notes also. This is the plan of this MGR University CBME curriculum. So I am going to discuss one of the important papers in March 2025. MUHS will be having, I think it will be the same, but there is another discussion, it will be discussed soon. This is purely MGR University paper session only for Tamil Nadu MGR University students. So this is mainly for Tamil Nadu MGR University students. And third professional exam, paper 1, general surgery paper of March 2025. I'm going to discuss one of the interesting question. So this is a very commonly asked question in every exam. The pattern may be the same, but the questions are not same. The questions are totally different. In MUHS, we are seeing different types of questions, and MGR University, it's different. So this session, which we are planning now, is an MGR University session. So we will be discussing MUHS also, Maharashtra session later. But this is a demo session of general surgery based on March 2025 on essay question. So each essay question will be maximum discussed for only 1 hour. And you should be able to write the questions according to the time constraints. So this is a 3 hours paper. You can see it's a 3 hours paper. Essay question, you should focus only for maximum of 30 minutes. You should not write even up to 30 minutes. You should not write. You should finish as much as possible. 30 minutes is a time for your essay questions. Finish in 30 minutes. Writing the exam, try to finish each essay in 30 minutes. That's most very important. So diagnosis of this case. 60 years old man presented with weakness, anemia associated with vomiting of indigested food. He has abdominal distension. What is the probable diagnosis? What are the etiopathogenesis of this condition, staging and management? You can see in the CBME curriculum, they are giving split up marks also. So you should not waste time on unwantedly some discussion. So focus on only the question paper. What is asked, you write only about that. So this case is a case of a gastric outlet obstruction. A case of diagnosis is a case of gastric outlet obstruction. So considering the age and other things, probably they're not asking the definite diagnosis. Probable diagnosis is, what is your probable diagnosis? So please don't make mistake in the first 2 marks, because once you make mistake in the diagnosis of a clinical condition, the entire essay will be gone. So be careful in attending the clinical question. Probable diagnosis is carcinoma stomach. Carcinoma stomach. Location of the cancer will be probably in the distal stomach. Distal stomach cancer. This is a classical history. And why I'm saying this is cancer stomach, you can see the patient is having all the clinical features of cancer stomach. So what are the clinical features means? You can see the patient is having anemia plus GOO features plus weight loss. So these features are more in favor of cancer. More in favor of cancer. They didn't even ask the differential diagnosis. So no need to even write about differential diagnosis of gastric outlet obstruction in this paper. So just diagnosis. When you're going to give a correct diagnosis, you got a 2 mark in this. So a case of gastric outlet obstruction, probably due to cancer stomach, distal stomach cancer, which is the more accurate, and the symptoms favoring in cancer are anemia, GOO, weight loss. So I will go for cancer stomach. So next, coming to etiopathogenesis of this condition. They are asking what are the etiology of cancer stomach. So you can write the etiopathogenesis of cancer stomach is smoking, spirit, spicy foods, salted foods. This is going to carry only 3 marks. So you be concise with this: smoking, spirit, spicy foods, salted foods, smoked foods, stored foods. So remember the mnemonic 6 yes. The mnemonic for this is 6 yes. So the etiological factors are 6 yes. First important. No need to write the mnemonics and all in the paper, essay paper. For understanding purpose, I am writing 6 yes, one set of risk factors, and 4A. Other set of risk factors are blood group A. You can in fact make a table and write the risk factors one by one. Blood group A, atrophic type of gastritis, adenomatous polyps, and one more A stands for, what is another A? One anemia called as pernicious anemia. One anemia called as pernicious anemia. This is 4A. See, be fast. You should finish off the writing in 30 minutes. The discussion will be for 1 hour, but you should write the question paper in 30 minutes. 6 yes, 4A, and HM. I used to tell HM. What is H stands for? I'm just writing the mnemonics for understanding purpose. You need not write the mnemonics and all. H. pylori. Helicobacter pylori is having a toxin production called as CAG-A toxin. And this H. pylori causes distal gastric cancer, not proximal gastric cancer. H. pylori causes distal gastric cancer. Don't forget this. H. pylori. And what is M stands for? Menetrius disease. Menetrius disease. In the bracket, you can write as protein-losing gastropathy. Protein-losing gastropathy, you can write. So protein-losing gastropathy. So this is a history. Clinical features are already given in the history. So they are not asking what are the clinical features of cancer stomach. So no need to write and waste time on writing the clinical features. So the patient is having abdominal distension, is probably a ascites. From the history, ascites is also present. So this is all favor me towards cancer stomach. Anemia, gastric outlet obstruction, weight loss, ascites, all these favor more in cancer. So etiopathologically, what are the risk factors? I have written very clearly the 6S, 4A, 1H, and 1M. These are the risk factors of cancer stomach. So writing essay question should be able to recall the contents as fast as possible. Okay, so don't forget this 6S, 4A, H, and M. And there is a very important risk factor called as genetic risk factor. Genetic risk factors. What are the genetic risk factors? Genetic risk factors, most important is E-cadherin mutation. Should write about E-cadherin mutation. E-cadherin mutation causes diffuse type of gastric cancer. Pathologically, there are 2 types of cancers. E-cadherin causes diffuse gastric cancer. E-cadherin causes diffuse gastric cancer, and along with diffuse gastric cancer, it also causes lobular cancer of breast. It also causes lobular cancer of breast. So very important mutation. E-cadherin mutation is number 1. And number 2, P53 causing Life-Frommeni syndrome. That is also going to cause diffuse gastric syndrome, gastric cancer. Life-Frommeni syndrome also causes diffuse type of gastric cancer. Diffuse type of gastric cancer. So other cancers associated are with familial adenomatous polyposis with the APC gene mutation. So FAP causing APC gene mutation, Lynch syndrome having HNPCC, hereditary non-polyposis colorectal cancer mutation. Please remember BRCA2 mutation, and also Peutz-Jeghers syndrome. So these are all other types of genetic associations in gastric cancer. And first 2 causes diffuse type cancer, and this causes intestinal type of cancer. Intestinal gastric cancer is associated with the last four types. So most important mutation here is E-cadherin mutation. Okay, E-cadherin mutation is the most important mutation seen in gastric cancer. P53 is Life-Romani syndrome causing diffuse gastric cancer. FAP, Lynch syndrome, BRCA2, Peutz-Jeghers syndrome are the other genetic risk factors. So here, I want to tell you two important pathological types because they have asked about the pathogenesis. So I thought of writing pathological types of gastric cancer. What are the two pathological types of gastric cancer? No need to write in detail, just write it as Lawrence classification of pathological types. That is, Lawrence classification is two types of pathological types of gastric cancer. Number one is diffuse. Number two is intestinal. Please remember the two types of cancers. Intestinal and diffuse are the two types of Lawrence gastric cancer. In intestinal type, we have well-differentiated cells. Well-differentiated cancer cells are seen. Okay, they are well-differentiated cells, and it is most common. It is seen most commonly in old men, and it is associated with environmental risk factors. Environmental risk factors is a cause of intestinal gastric cancer, like smoking, spirits, spicy foods, all those things causes intestinal gastric cancer, and it is H. pylori positive. Please remember H. pylori positive. So you write, put a table, you can make a table and write the pathological because they're asking etiopathogenesis. So you can write a few points about the two pathological types, diffuse and intestinal. Diffuse type is of signet ring cell pattern. Signet ring cell pattern. So signet ring is the cells with the nucleus pushed towards the periphery is called as signet ring cell. It is less common. It is most common in young females due to genetic risk factor. It is a genetic risk factor. Like E-cadherin is a main culprit of diffuse gastric cancer, especially E-cadherin, and H. pylori may or may not be positive. So two types of cancers, diffuse and intestinal. Diffuse is most common in proximal stomach. Diffuse is common in proximal stomach. Intestinal type is most common in distal stomach. Don't forget this point. So distal stomach. Intestinal type is common in distal stomach. See, writing this itself already went around 15 minutes. So you should be very careful in writing the essay questions. Sometimes when you have a very well-known essay question, you keep on writing unwantedly lot of points, and finally you will have no time to finish the paper. So be careful. You keep the maximum time as 30 minutes. 10 minutes may come extra, but keep it as maximum 30 minutes. That will be ideal for an essay question writing in the exam. So this is the etiopathogenesis of gastric cancer. That is given 3 marks according to the question. And the next point is what is the staging of this condition? So staging is given 4 marks from this. So the latest staging is AJCC 8th edition. Please remember AJCC 8th edition staging, they're asking about TNM. T1, what is T1? T1 is mucosa and submucosa. Mucosa and T1A is mucosa. T1B is tumor infiltrating up to submucosa is T1B. So very simple. Don't need to write in detail, but just know the basics of staging. T1 is mucosa, submucosa. T2 is the tumor has gone to the muscularis level, muscularis propria level. So T3 is very important for MCQs and PG entrance exams. Subserosal tissues. Subserosal tissues include infiltrating ligaments without involving the peritoneum. Ligaments like lesser omentum, greater omentum. But in these ligaments, it has not gone to the, not involves visceral layer, visceral peritoneum. It has not gone to the visceral peritoneum. It is only involving subserosal tissues. In the ligaments, it has infiltrated, but not involves visceral peritoneum. So T4 is very important. T4 has gone to the serosal involvement present. Serosal involvement is present, and ligaments are infiltrated into the ligaments infiltrated to the visceral peritoneum. So ligamental infiltration to the visceral peritoneum. So this is called as T4A. So T4A has gone to the serosa of the stomach or to the ligaments of the visceral peritoneum, and T4B is adjacent organ involvement. So can you write what are the adjacent organs which can be infiltrated by this? That is coming under T4B. So in adjacent organs, you can write liver, pancreas, spleen, colon, all this come under adjacent organs. So adjacent organs include the cancer stomach can infiltrate into liver, infiltrate into pancreas, spleen, or colon. So these are the adjacent organ involvement is T4B. And coming to N1, N1 is 1 to 2 nodes positive. Pathologically, when I examine 1 to 2 nodes positive is N1, 3 to 6 nodes positive is N2, N3 is 7 to 15 nodes positive is N3A. More than or equal to 16 nodes is N3B. So therefore, in a cancer stomach, the minimum node should be examined is how much? Yes, minimum nodes that should be examined in a cancer stomach should be 16 nodes should be examined minimum. Please don't forget this. Minimum of nodes to be examined in cancer stomach is 16 nodes should be examined in cancer stomach. So N1, 1 to 2 nodes, N2, 3 to 6 nodes, N3 is 7 to 15A, more than 16P. And coming to M1 is METS. METS is most common to which place? Metastasis is most common to peritoneum. Peritoneal METs are most common, and the various types of peritoneal METs we know very well with the names are Bloomer's shelf is a peritoneal METs. Bloomer's shelf is a peritoneal METs. Krukenberg's tumor, bilateral ovarian METs is a peritoneal METs. Okay, ascites with a peritoneal spread is also a peritoneal METs. Ascites is also a peritoneal METs. So Bloomer's shelf, Krukenberg's tumor, ascites, and other metastases include liver secondaries. Liver secondaries is another peritoneal METs. Liver secondaries is another peritoneal METs. Liver secondary is another peritoneal METs, and liver secondary is another distant METs, or going to the other distant METs. Any distant METs will come under M1. Please don't forget, this all will come under M1. So this is the TNM staging they're asking. You should write about the AJCC TNM staging of cancer stomach. And now the most important thing you should remember is early gastric cancer. You should write a few lines in the staging. What is early gastric cancer? Early gastric cancer is diagnosed most commonly in Japan due to Japanese do routine screening investigation. Due to screening endoscopy, in Japan, they diagnose most of the early gastric cancers. And early gastric cancers, as per Japanese, includes what are the cancers? In early gastric cancer, we have T1 cases, nothing but mucosa with or without submucosa, and with or without nodes. This is the definition of early gastric cancer. Early gastric cancer is defined by tumor involving mucosa and submucosa with or without nodes. This is early gastric cancer. So don't forget, early gastric cancer patients, when they are staged, are easily removed by endoscopic submucosal dissection, or by endoscopically, we can remove the tumor instead of gastrectomy. Endoscopic mucosal resection. So early gastric cancer is nothing but mucosa with or without submucosa, with or without nodes. These are called as EMR and EST. So since we are writing about the staging, we can add a few points. But what they have given is 4 marks only for TNM staging. Staging of the cancer, they are giving 4 marks. So you write about the staging. Stomach cancer staging will be definitely asked in exam, especially for final years. T1 mucosa, submucosa, T2 muscle layer, T3 subserosal tissues, T4 serosa. So 1 to 2 nodes, 3 to 6 nodes, 7 to 15, more than or equal to 16. See, you can make the presentation very nice by making small tables, by making small pictures, everything you can do. If you have adequate time, you can do all those things. So now the last part of the essay question was major mark is given for this, 6 marks is given for management. So now you should focus more on management. Management includes both investigations as well as treatment. So let us now discuss about the investigations of cancer stomach. So investigations of cancer stomach, please don't forget, we should write the table. You make a table of basic investigations, what will be done for cancer. Any cancer, what are the basic any patient, what are the basic investigations you do? And the specific investigations, what will you do? And most importantly, staging investigations, what will you do? This is a 3 category you should write for any cancer related question. So basic investigation I will do is, first I should do a serum electrolytes, because patient is vomiting. So definitely the patient will have a serum electrolyte investigation will be done, and the examiner will be attracted to, if you write, patients may have hypochloremic, hyponatremic, hypokalemic. Yes. What will be the finding? Hypochloremic, hyponatremic, hypokalemic. See, this is actually a discussion session. You can post in this, you can post the questions. You can always post the questions. If you have doubts, you can always post in the session. Please post your queries in the chat box. So I think, so what is seen? Hypochloremic, hyponatremic, hypokalemic, metabolic alkalosis is seen. Metabolic alkalosis is a clinical finding seen in these patients. So hypochloremic, hyponatremic, hypokalemic, metabolic alkalosis will be seen in the serum electrolytes, and do complete blood count. What do you find in this investigations? You can write on the side. In a complete blood count, I will see hemoglobin, low hemoglobin will be seen, because there is a bleeding may be seen from the cancer. So the patients may have low hemoglobin. And I will do the renal function test and liver function test for surgery purpose. For surgery purpose, I should do liver function test, renal function test, X-ray chest, and ECG. These are all for surgery purpose. I'll be doing all these investigations. So the basic investigations I'll do is complete blood count, electrolytes, renal function test, liver function test, X-ray chest, and ECG. So now the most important question is specific investigation of choice to diagnose cancer stomach is. So the investigation of choice to diagnose cancer stomach is what? Yes, what's the answer for this? You should post the doubts or queries. Then only if you post the answers, then only we will also get an idea how much you are responding, and we will be taking the class accordingly. Please post what is the investigation of choice to diagnose cancer stomach. This patient is having gastric outlet obstruction. Therefore, what will I do? Gastric lavage followed by, I will do a gastric lavage followed by endoscopic biopsy. First, you should do a gastric lavage. There will be full of food particles. Very good, Adityan. That's correct. So do a gastric lavage. Put a white bore tube. Wash the stomach fully. Then only you should refer the patient for endoscopic biopsy. That is the investigation of choice. That is a specific investigation for cancer stomach. So investigation of choice to diagnose cancer stomach, if they ask you, the best answer is endoscopic biopsy. So barium meal is now replaced by endoscopy. Barium meal is useful in cases of Linitis plastica. Will help you to find out a contracted stomach. So Linitis plastica, barium meal may be useful. And we can also use specific investigations like endoscopic ultrasound for staging of the cancer stomach. So see, endoscopic ultrasound is another very important update investigation. Endoscopic ultrasound for T staging and N staging. So for T staging and N staging, which is best means endoscopic ultrasound is best. So though you may not write in detail, endoscopic ultrasound shows 5 layers. So what are the 5 layers? If this is an endoscopic ultrasound probe in the stomach, I will be seeing 5 layers of the wall. Please remember 5 walls can be seen. 1, 2, 3, 4, 5. These are the 5 layers on endoscopic ultrasound. And in the 5 layers, please remember second layer is hypoechoic, fourth layer is hypoechoic. Please remember this. This is the picture of endoscopic ultrasound. Second and fourth layer are hypoechoic. 1, 3, 5 is hyperechoic. 1, 3, 5 is hyperechoic. So what is 1? What is layer 1 is mucosa. 2 is muscularis mucosa. 3 is submucosa. 4 is muscularis propria. 5 is serosa. So 5 layers are seen. Therefore, if you have a cancer, you can find out up to what place it is infiltrating like this. You can find out up to what place the cancer is infiltrating by doing a EUS. So 2 and 4 are hypoechoic layers. 1, 3, 5 are hyperechoic layers. 2 and 4 are hypoechoic. 1, 3, 5 are hyperechoic. So therefore, with this, I can say which staging it is. T staging, I can find out with the endoscopic ultrasound. And similarly, node, metastatic node will have, you can draw this picture in the exam, it will attract the examiners if you have adequate time. Metastatic node will have more than 1 centimeter round and hypoechoic. So round and hypoechoic. So endoscopic ultrasound for T and N staging, you can see 5 layers of stomach wall, and also metastatic node also can be picked up. So endoscopic ultrasound is one commonly done investigation for T staging and N staging. For CECT abdomen is what done in many centers, especially if you are from any government medical college. Most of our institutes don't have EUS. So we depend on CECT abdomen for T and N and M staging can be done. So T and M staging can be done with the help of CT abdomen. CT abdomen will help you to diagnose where is the cancer, which layer it is infiltrating, everything you can find out. And for M staging, specifically M staging, we have some special investigations. Can you tell me what all special investigations you should do? FDG, fluorodeoxyglucose, PET CT for diagnosing distant meds. Please remember, for diagnosing distant meds, we should do fluorodeoxyglucose, PET CT scan. And one more investigation is very important to diagnose peritoneal meds. Can somebody tell me what is it? Peritoneal meds are best. Which investigation is best to diagnose peritoneal meds? Anybody? Which is the best to diagnose peritoneal meds? Can you tell me? Yes. Diagnostic laparoscopy. Diagnostic laparoscopy is the best to diagnose peritoneal meds. Very good. So diagnostic laparoscopy is the best to diagnose peritoneal meds. So peritoneal meds and distant meds are diagnosed before operation. So what are the investigations done means endoscopic ultrasound is for T and N staging, CT abdomen for T, N, M staging. Especially it helps in diagnosing liver mets and all is very well picked up by CT abdomen. So liver mets can be picked up, and what is the layer it is infiltrating adjacent organs. Everything we can find out with the help of CT abdomen and M staging. So these are the investigations I should do. So in the management, it includes both investigations as well as treatment. So now I am going to discuss the treatment of this 60 years male who came to my hospital. So treatment of this patient is, please remember, this patient is having a gastric outlet obstruction. So the first management of me will be, what is it? Electrolyte correction. Otherwise, patient will die. This is the examiner will be waiting to see whether you have written electrolyte correction. So what is the fluid that should I give for electrolyte correction? That is hypokalemic, hyponatremic, metabolic alkalosis. So the fluid of choice is normal saline. Normal saline should be given as a fluid of choice. So don't give ringer lactate. Ringer lactate is contraindicated because it's a case of metabolic alkalosis. What happens if I give ringer lactate in metabolic alkalosis? Ringer lactate is contraindicated. If you give ringer lactate, lactate gets converted in the liver to bicarbonate, and it will aggravate the metabolic alkalosis. So aggravates metabolic alkalosis, and you will naturally kill the patient by your fluids. So aggravates metabolic alkalosis. So you should never give ringer lactate. Don't give ringer lactate. Give normal saline, and you can give KCl supplement if there is so much of hypokalemia. KCl supplement can be given in injection forms also. When there is so much of hypokalemia, nothing wrong, you can give KCl supplement. So please remember, first management is electrolyte correction and prepare the patient for surgery. Prepare the patient for surgery. We cannot directly take the patient for surgery tomorrow. So prepare the patient for surgery. First, put a Riles tube and do wash for 3 to 4 days. You have to do Riles tube wash. Riles tube wash should be given. Apart from electrolyte correction, if the hemoglobin is less than 8 grams per deciliter, go for a blood transfusion also. Blood transfusion should be done. See, for albumin, if serum albumin is very low, please understand, if serum albumin is less than 3.5 grams per deciliter, it is a time you should improve the nutrition by either total parenteral nutrition along with albumin infusion should be done. So you cannot operate a major surgery of gastrectomy in a patient who is already having a low albumin. So prepare the patient, Riles tube wash, correct the hydration, electrolyte and fluid correction, electrolyte plus fluid correction. All these are very important steps in patients before taking the patient for surgery. So this case is specifically a case of distal gastric cancer. So you need not write everything about the management of cancer stomach. So therefore, surgical management of an operable case. If this case is operable, surgical management. So this patient, let us assume this is a patient who is operable. So I will plan for this is a picture of the cancer. So let us assume this is a patient with a cancer in this distal place, having a cancer stomach with gastric outlet obstruction, So now if on laparotomy, if the patient is operable, what surgery will I do? If it is operable with no meds, nowhere there is meds, patient is operable, what will I do? If it is inoperable, probably there is a peritoneal meds. During surgery, I found out here, peritoneal meds. What will I do? So 2 surgeries I have to explain here. So if the case is operable cancer with no meds, nothing, I will go for what surgery is done? What is the name of this surgery? You can draw the picture instead of writing the theory. This is a picture showing you subtotal gastrectomy with a subtotal gastrectomy. This patient is done a subtotal gastrectomy plus Billroth 2 reconstruction. This is called as Billroth 2 reconstruction. This picture shows subtotal gastrectomy plus Billroth 2 reconstruction. So in this subtotal gastrectomy Billroth 2 reconstruction, I will also do D2 lymphadenectomy. So they have not asked the details of lymphadenectomy nodes, and also I'm not going into that. So D2 lymphadenectomy means removal of nodes from which station? Removal of nodes 1 to 6 is level 1 node. 7 to 11 is level 2 nodes. And also I will remove 12A, which is a anterior hepatoduodenal nodes. So I will remove these nodes. So in a case of gastric cancer, I will do D2 lymphadenectomy of removal of 1 to 6, 7 to 11, and 12A. And in this, the MCQ you should not forget for your PG entrance exams is margin given for cancer stomach is 5 centimeter from substem. 5 centimeter for margin should be given, and number of nodes removed is 16 nodes should be minimum. Minimum, you should remove 16 nodes for a proper. So in an operable cancer, you will go for a major surgery of subtotal gastrectomy with the Billroth 2 reconstruction along with the D2 lymphadenectomy will be done. So don't forget, there is a surgery done for an operable cancer is D2 lymphadenectomy is done for all the patients. If it is an inoperable due to peritoneal meds, the surgery is done in a different manner. The operation done is like this. If there is a cancer here, I will go for patient has a GOO. So I will go for a palliative gastrojejunostomy. Palliative gastrojejunostomy is done for inoperable cancers. For inoperable cancers, I will go for palliative gastrojejunostomy. So cancer stomach, please remember, operable cancers, we will go for a subtotal gastrectomy with Billroth 2 reconstruction. And for inoperable cancers, we go for a palliative gastrojejunostomy. We go for a palliative gastrojejunostomy. And after surgery, we should give them adjuvant chemotherapy. In an operable case, we should give them adjuvant chemotherapy. So adjuvant chemotherapy, old regimen was Cunningham's regimen of ECF is an old regimen. It is removed in New Bailey. Old regimen of Cunningham's regimen. This is called as Cunningham's regimen, which we were reading for 20 years. Epirubicin, cisplatin, 5-FU. This is adjuvant chemotherapy given in the olden days. In fact, you need not write this at all. You can write the latest regimen called as Plot 4 regimen. Is the latest regimen of cancer stomach. Latest adjuvant regimen is Plot 4, 5-FU. F stands for 5-FU. L stands for leucovorin. O stands for oxaliplatin. And T stands for taxanes. So this is Plot 4 regimen is the latest regimen given. So this completes the essay writing of the university exam. This is more than enough. You can see from the essay writing, I have given the clear concepts of 60-year-old man presented with weakness, anemia, vomiting of undigested food, maybe having an abdominal distension, maybe due to ascites or maybe due to GOO having VGP. So probable diagnosis, this is the case of cancer stomach with the distal stomach cancer. Proximal cancer will not cause abdominal distension or GOO or undigested food. So probably this is a case of distal stomach cancer. And etiopathogy is you should write about all the clinical features you know. See, this is the theory exam. Even if you miss 1 or 2 points, it is not to worry. So don't worry. It doesn't mean you should write everything. But important highlighted points you should not miss. When you're writing genetic factors, you should not miss E. cadherin mutation. So it is nothing but the gene is called as CDH1 gene. This gene mutation causes diffuse gastric cancer and lobular breast cancer, very high risk. And never forget, Lawrence classification is a pathological types of gastric cancer. We have diffuse and intestinal. The commonest cancer what we see in practice is intestinal. Diffuse is very rare and it has very bad prognosis. Intestinal has comparatively good prognosis. Please write about the TNM staging like this, TNM. To write about it. And the early gastric cancer, you should know about, write a few points about early gastric cancer during the staging itself. It is nothing but mucosa with or without submucosa involvement, with or without nodes. So it is easily treated by simple surgery. So whenever there is a question on management, don't only write treatment. So management is what are you going to do for the case? It includes investigations as well as treatment. So don't forget, the examiner will be expecting you to write about electrolytes in the question paper. When you write electrolytes, you should write metabolic alkalosis due to hypochloremic, hyponatremic, hypokalemic metabolic alkalosis. Should never miss. And the investigation of choice is going to be endoscopic biopsy is the best. And in your hospital, in most of our Tamil Nadu medical colleges, I think no college, including Madras Medical College, does not have endoscopic ultrasound as of now. So therefore, even if you miss writing anything about EUS, nothing wrong. You should write definitely CT abdomen is commonly done by us in practice. And we always do diagnostic laparoscopy before proceeding for any operation of operable cancers. So treatment, we should do electrolyte correction first. That's the most important thing examiner will be waiting, whether you are writing about electrolyte correction using normal saline. So normal saline is the fluid of choice. Don't use ringer lactate. No need to write it, just I'm writing for understanding purpose. You write normal saline with the KCl supplement is the fluid of choice. So most important thing in a GOO case is prepare the patient with the Riles tube wash, blood transfusion, albumin infusion, or parenteral nutrition. Improve the nutrition before taking for gastrectomy. So the surgical management depends on whether the case is operable or inoperable on diagnostic laparoscopy and other situations. Inoperable cases, we only go for palliative bypass. So that until he is going to live, let him eat peacefully. In an operable cancers, we go for a major surgery, subtotal gastrectomy with the Billroth 2 reconstruction and D2 lymphadenectomy will be done. So please write a few lines about the adjuvant chemotherapy, especially the latest regimen used is plot 4 regimen. So this is about the essay question. This, please remember, you should write the essay questions. Timing of writing should be very serious. Between 30 to 40 minutes should be the maximum for essay question. Don't waste too much of time on writing essay question, and draw pictures wherever possible. Draw tables and pictures that will attract the examiners, and they will give you more marks when you draw tables and pictures. So please remember these basic things in your exam. So any doubts, if you have in this topic, please post. If you're having any doubts, please post the doubts. Having any doubts? This is about the university essay question discussion on GO. So you'll be having last three or 4 years paper. We are going to discuss 25 essay questions in this session. That is the plan of this session, is to discuss about 25 essay questions. And based on the number of registrations and the response from the students, we'll be also discussing short notes. And future, we'll also discuss about the clinical questions also. Clinical topics also we will try to discuss, or we will add the recorded clinical lectures in the app. So hope you all understood how to write an essay question for this topic. Any doubts, or shall we stop? Thank you. Thank you, Vaibhav. Thank you, Adityan. Thank you so much. So see you all in another session soon. Next session will be coming soon. There will be another session soon.